Necrosis is the premature death of cells and living tissue. It can be caused by various factors, including infection, toxins, or trauma. Unlike apoptosis, which is programmed cell death, necrosis is an unplanned process resulting from acute cellular injury. When cells undergo necrosis, they exhibit characteristic changes. Necrosis has several key characteristics that distinguish it from other forms of cell death. First, cells undergo swelling as their ability to maintain volume control is compromised. Next, the plasma membrane ruptures, compromising cellular integrity. This rupture leads to the release of cellular contents into the surrounding tissue. Finally, the release of cellular components triggers an inflammatory response in surrounding tissues. This inflammatory response is a key distinction between necrosis and apoptosis. It involves the recruitment of immune cells, increased blood flow to the affected area, and the classic signs of inflammation: redness, heat, swelling, and pain. Understanding the definition and characteristics of necrosis is fundamental to recognizing its causes and clinical manifestations. Necrosis has multiple causes, all leading to premature cell death and tissue damage. When cells are exposed to harmful stimuli, they undergo necrosis, an uncontrolled form of cell death. Physical trauma is a common cause of necrosis. This includes crushing injuries, burns, and freezing conditions like frostbite. These injuries directly damage cell structures. Infections from bacteria, viruses, and fungi can cause necrosis by directly invading tissues or releasing harmful substances. Toxins like snake venom, chemicals, and radiation damage cells by disrupting critical cellular processes or directly destroying cell components. Vascular issues like arterial blockages, venous thrombosis, and compartment syndrome cause necrosis by reducing or blocking blood flow to tissues. Chronic diseases, particularly diabetes mellitus, can lead to widespread tissue necrosis due to poor circulation and nerve damage. While the initial triggers of necrosis vary, they all ultimately disrupt cellular homeostasis, leading to the same outcome: uncontrolled cell death and tissue damage. Necrosis manifests in 6 major types, each with distinctive microscopic and clinical characteristics. Coagulative necrosis is most common type, seen in heart attacks, myocardial infarction. Tissue architecture is preserved, but cells appear denser and more eosinophilic due to protein denaturation. It is typically found in men, common in organs with high protein content: heart, kidney, liver. Liquefactive necrosis is tissue completely digests and liquefies due to enzymatic dissolution. The affected area becomes soft and may form a cavity filled with fluid. It is typically found in brain infections, abscesses, and inflammatory conditions. Caseous necrosis is characterized by cheese-like appearance with granular debris, combination of coagulative and liquefactive features. Has a crumbly white appearance. It is typically found in the clone, typical in tuberculosis and other granulomatous diseases. Fat necrosis occurs in fatty tissues where lipases release fatty acids that combine with calcium to form soaps, saponification. Appears as chalky white areas. It is typically found in pancreatic inflammation, breast tissue trauma. Fibrinoid necrosis is characterized by fibrin-like protein deposits in blood vessel walls. Appears bright pink in H&E staining, associated with immune complex deposition. It is typically found in blood vessels in immune-mediated vasculitis and malignant hypertension. Gangrenous necrosis is a combination of coagulative and liquefactive necrosis in large tissue areas, often due to vascular compromise. Tissue turns black, dry gangrene, or may liquefy, wet gangrene. It is typically found in enamel, most common in extremities, toes, fingers, in conditions like diabetes. Let's review the 6 major types of necrosis, each with distinctive features and typical locations in the body. Necrosis begins with the depletion of ATP, the cell's energy currency. This reduces the function of cellular pumps and energy-dependent processes. Calcium dysregulation follows, with an influx of calcium ions into the cell. This activates calcium-dependent enzymes that degrade cellular components. Necrosis progresses through distinct stages. First, the cell swells as ion pumps fail. Then, organelles begin to dysfunction and the membrane starts to lose integrity. At the subcellular level, mitochondria swell and lose function, the endoplasmic reticulum dilates, and nuclear DNA becomes fragmented. The cytoskeleton also starts to disintegrate. While apoptosis is a controlled, programmed cell death process, necrosis is uncontrolled and leads to inflammation as cellular contents spill into surrounding tissue. The final stages of necrosis involve complete membrane rupture and the release of cellular contents. This triggers inflammation as immune cells respond to the released material. Clinical manifestations of necrosis vary depending on the location and extent of tissue damage. Locally, necrosis typically presents with classic signs of inflammation and tissue damage. Pain, swelling, redness, and heat are common inflammatory responses to tissue death. These signs occur as the body responds to dying tissue by increasing blood flow and immune cell activity. Patients also experience loss of function in the affected area as the tissue deteriorates. As necrosis progresses, the affected tissue undergoes characteristic changes at the cellular level. Under the microscope, necrotic cells show characteristic changes including swelling, membrane rupture, and degradation of cellular components. Visibly, the tissue changes color as it dies, beginning with pallor, then darkening, and eventually turning black in severe cases. In severe cases, like this example of digital necrosis, tissue turns black and begins to break down as cells die completely. Beyond local changes, necrosis can trigger systemic responses throughout the body, especially when extensive or involving infection. Fever is a common systemic response as the body attempts to fight infection or clear dead tissue. White blood cell counts increase as the immune system mobilizes to address the tissue damage. Patients may also experience increased heart rate, general malaise, and elevated inflammatory markers in the bloodstream. The overall clinical presentation of necrosis will vary depending on the location of the affected tissue, the extent of damage, the underlying cause, and whether infection is present. Diagnosing necrosis involves multiple approaches, including clinical examination, imaging studies, laboratory tests, and tissue biopsy. Imaging techniques are crucial for visualizing necrotic tissue. MRI is particularly useful as it can detect subtle changes in tissue water content. Laboratory tests can detect inflammatory markers and specific enzymes released from damaged tissues. These enzymes are specific to certain organs, such as troponin for heart damage or amylase for pancreatic necrosis. Tissue biopsy remains the gold standard for diagnosing necrosis. It provides definitive diagnosis, determines the type and extent of necrosis, identifies underlying causes, and guides treatment decisions. This microscopic image shows inflammatory cells surrounding blood vessels in necrotic tissue. The pathology workflow begins with specimen collection, followed by fixation, processing, sectioning, and staining. After preparation, pathologists examine the slides to diagnose necrosis and determine its characteristics. To summarize, diagnosing necrosis involves a multifaceted approach. Clinical examination identifies affected areas, imaging techniques visualize necrotic tissue, laboratory tests detect markers of tissue damage, and biopsy confirms the diagnosis. Early diagnosis is critical for effective management. Treatment of necrosis focuses on 4 key goals: addressing the underlying cause, removing necrotic tissue, promoting healing, and preventing complications. Medical treatments focus on addressing the underlying causes. This includes antibiotics for infections, improving blood supply to affected areas, controlling blood sugar in diabetic patients, and eliminating exposure to toxins. Diabetic foot ulcers represent a common form of necrosis that requires comprehensive medical management. Control of blood glucose levels is essential to prevent progression. Surgical debridement is a critical intervention for necrosis. This procedure involves removing dead or damaged tissue to allow healthy tissue to heal properly and reduce the risk of infection. For extensive necrotic wounds, skin grafting may be necessary. This procedure replaces damaged skin with healthy skin harvested from another part of the body. The graft can be meshed to cover a larger area and is secured with staples or sutures. Hyperbaric oxygen therapy is an advanced treatment for necrosis that increases oxygen delivery to tissues. Patients breathe pure oxygen in a pressurized chamber, which promotes healing, reduces inflammation, and helps fight infection. For bone necrosis, the body's natural remodeling process can help repair damage. Osteoclasts remove damaged bone tissue, while osteoblasts form new bone matrix. In some cases, surgical intervention may be necessary to support this process. In severe cases of necrosis, amputation may be required. This procedure is a last resort when necrosis is extensive and threatens to spread to healthy tissue. Amputation prevents systemic complications that could be life-threatening. Necrosis, if left untreated, can lead to several serious complications with potentially life-threatening consequences. These complications vary in severity and can affect both local tissues and the entire body. When infection spreads from necrotic tissue to the bloodstream, it can trigger sepsis, a life-threatening condition. The sepsis cascade involves complex inflammatory and coagulation responses throughout the body. Necrotic tissue can lead to chronic non-healing wounds that resist standard treatment. These wounds remain in a state of persistent inflammation with biofilm formation and impaired blood vessel growth. Extensive necrosis can trigger disseminated intravascular coagulation, or DIC, a serious condition where blood clotting becomes dysregulated. This leads to organ damage, as seen in these microscopic views of glomerular injury. Necrosis often results in permanent loss of function and anatomical deformity. Destruction of vital structures like nerves and blood vessels, along with dense scar formation, can lead to contractures and impaired tissue function. Extensive necrosis can trigger a systemic inflammatory response syndrome, or SIRS, characterized by a cytokine storm that affects distant organs. This can progress to multiple organ failure, a condition with high mortality rates. Early recognition and aggressive intervention are crucial to prevent these potentially devastating complications of tissue necrosis. With proper treatment, many of these complications can be minimized, protecting both tissue function and patient survival. Prevention strategies for necrosis depend on the underlying cause, but generally focus on 4 key areas. Proper wound care is essential. This includes cleaning wounds immediately, applying appropriate dressings, and monitoring for signs of infection. Managing chronic diseases, especially diabetes, helps prevent tissue necrosis. Controlling blood glucose levels, regular foot inspections, and proper foot care are crucial for diabetic patients. Maintaining good circulation through regular physical activity, avoiding prolonged sitting or standing, and smoking cessation can prevent tissue death from poor blood supply. Avoiding exposure to toxins and chemicals that can damage tissues is critical. This includes proper handling of known toxins, using protective equipment, and avoiding substance abuse. The prognosis of necrosis varies widely based on several key factors. The extent of necrosis significantly impacts prognosis. Earlier stages with limited cell death have better outcomes than advanced necrosis with extensive tissue damage. Ongoing monitoring through advanced techniques like liquid biopsy can help track disease progression and guide therapeutic decisions. The prognosis spans a wide spectrum. Favorable outcomes are associated with limited necrosis in non-critical organs, early intervention, and good overall health. Poor prognosis is seen with extensive necrosis in critical organs, delayed treatment, and compromised health. The key takeaway is that early detection and appropriate intervention significantly improve outcomes in patients with tissue necrosis.
If you enjoyed this video and would like to practice your understanding, go to MatEazy.com. There, you'll find this lesson outlined and divided, with a short quiz to see how well you really understood it. And if you're hungry for more, we've got piles of other topics for you to explore. Start learning easier. Visit MatEazy today.